afternoon, everyone, and welcome to our webinar today. My name is Pam Power, and I'm the Associate Chief Nursing Officer here at Tipton. And I want to invite you into this wonderful hour. I'll introduce our guest for this hour. But first, let me start at the beginning by letting you know that we do offer contact hours, 1 hour for this time together. When you complete the webinar, we'll ask you to just use the link and complete the evaluation. The contact hours come from the California State Board of Nursing, and they will be sent to you in your email. But in order for that to happen, we do need you to, first of all, enter your name exactly as you want to see it on your certificate, and then your email correctly. So take a look at it twice so that we know it actually will come to you through an automated system. So we want to make sure that it gets to you properly. We also want you to know that we don't have any conflict of interest here at Tipton. We are nurses, serving nurses, helping nurses, inspiring nurses, and we hope that this hour together serves all of you very well. So let me introduce our fabulous guest for this hour, and she is Dr. Lucia Wocial, and she comes to us from the MedStar Health system. But let me tell you a little bit about her. Her academic journey came from the Oregon Health Sciences University, so a West Coaster, but she is currently at the MedStar location in that kind of DC area. Her current research focuses on moral distress, particularly with caregivers, particularly in the intensive care setting. Her clinical background for many years was neonatal intensive care nursing, and she served as a clinical nurse specialist in that intensive care setting. She is a nursing ethicist who has a long and storied career in ethics. She is a certified healthcare ethics consultant and serves on the Commission for Healthcare Clinical Ethics Consultation Certification, so helps to steer that organization as we see people seeking that particular credential. She is also a faculty member at Indiana University, and her expertise in all that she has woven together is in ethics in difficult communication that takes place in that ICU setting, particularly around surrogate decision making. So many of our participants here may come from those settings. Dr. Wocial, we are so grateful for you to be here and bring your expertise on this really hot topic. We're always interested in things that elevate nursing in their work environment, and we know that being able to deal with these issues is essential. So
Thanks for having me.
oh,
I have to say, so I have an affiliation with Indiana University, although I'm no longer with their School of Nursing. I'm part of an NIH-funded grant, but I am adjunct faculty for Georgetown University. So that was my mistake in not sending you the right information.
wonderful. Thank you for that. Thank you. I want to turn it over to you and ask one question that will kind of get us started.
Mhm.
And that relates to the update in the ANA Code of Ethics. If
Mhm.
you can give us a little bit of a before and after, that might be a great place to start us off.
Sure. So I always, because I have an affiliation with an organization where I work and I've served on commissions, I always try and make sure that people understand what I'm expressing to you today are my views. So I'm not representing MedStar, I'm not representing the commission on which I serve, or even the Ethics Advisory Board for the American Nurses Association. So that was your disclosure slide for those who like visuals. So when you ask about the Code of Ethics, I think for me, one thing that a lot of people really don't appreciate is the American Nurses Association reviews and, as necessary, revises their Code of Ethics every 10 years. So what that means, in part to me, is it's meant to be a living, breathing document. Because if you think about what did it mean to be a good nurse or an ethical nurse 100 years ago, it is very different today. than what it was. And so when you embark on something like that, the journey of revising the current code, which was released in January, began in 2023. And it started with identifying content experts, people who were expert in nursing ethics. It included identifying writing teams. We had a process where we sought public input. After the public input, it went back. And I think a lot of people really don't appreciate the rigor of the process that was used for this. And also importantly, all of the people who were engaged in that, it's volunteer time. So it's a lot of people believing and valuing ethics to the extent that they will spend hours, and I do mean hours, working on all those pieces. When I think about sort of what makes this code slightly different, or where I would hope that people spend some time with it, the code really, for me, focuses on the essence of nursing. And it really encourages people, I mean, I encourage people to read, not just the code. We now have 10 provisions, so that's one thing that's new. But do not skip over the introduction and the preface. A lot of people will do that. I don't know if you're a book reader and you're like, I'll skip past the preface. I mean, what I would say is, if you read the introduction and preface, that really lays the foundation for understanding how we arrived at the provisions that we arrived at. One of the fun parts about this new version of the code is it's electronically available, so people can search it. If you think about where was the internet 10 years ago and where are we now? So that again speaks to our goal is to make it a document that any nurse can use. There are things in the code which I think some people may find challenging. If you understand and think about ethics, not everybody agrees. I tell people all the time, if you can focus on one thing that will guide you and help you understand the rest of it, it's respect and dignity for everyone. Everybody deserves to be treated with respect and dignity. Our patients, our colleagues, ourselves, all of us. And if you start there, that's an important point. I know it's impossible to think about the code without acknowledging the current climate with regard to healthcare. Our political climate can't be avoided. And so there is language in the code that may be inconsistent with some current executive orders on language that is appropriate to use. The language that was selected was based on who we think nurses are, what we think nursing is as a profession. So I think, for a lot of people, and we did get a lot of public comments about how should we frame things? What should be in the code? What can we leave out of the code? And that's another opportunity for me to remind folks that the code isn't the only document that guides practice. The American Nurses Association also has position statements. We have standards for practice. So it is meant to be part of something that can guide people in their practice. The newest provision deals with the recognition that nursing is a global practice. And so it focuses on global nursing. So that's a very long-winded way of saying, that's what I hope people take away from the code, that they use it and that they really pay attention to the pieces and parts.
Well, you said so many important things. I love that comment that if we think about treating people with dignity, it becomes our North Star. And allows
Yep.
us to maybe not get bogged down, but just think about the dignity of all.
Yep.
And the idea that our world is changing and sometimes can be tumultuous. I love that you said it's about who nurses are and who they are around the world. I so appreciate that. And interesting to think what changes in 10 years, let alone 20 years or 30 years.
Yeah. I think a lot has changed. I think a lot will change. If you think about even just the last year, I would say 5 years ago, how many people thought about artificial intelligence? You can't go anywhere without hearing about or thinking about it or knowing that it's going to have an impact on everything. So
Yeah.
a lot changes.
Yeah. And who could imagine what would be in the next revision based on the speed at which things are changing?
I'm not putting money on anything except that I hope dignity and respect remain at the center of what it is we do and who we are, who we hope to be.
Right, right. So true. And we know nurses continue to be the most trusted profession. So
Mhm.
we hope that we hold our heads high and keep that North Star in our practice.
Mhm.
So I want to take you to a little bit different place, and it's the discussion of moral distress
Mhm.
that you have invested so much in. And I wonder if you could talk a little bit about what is moral distress? What are the kinds of moral distress that nurses find themselves in most often? And what is the impact to nurses when they find themselves experiencing moral distress?
Yeah, I tell people all the time, I can talk to you about moral distress for 5 minutes or 8 hours, so I will spare you the 8 hour version. I will say, moral distress as a construct, as a concept, as a thing, has, I think, probably we're up to 50 or more different definitions. I never thought that I would embark on studying something that was as messy as moral distress has become, but here I am. So uh, there's a debate about what is the correct definition of moral distress. It comes from um, a word, a phrase that was created back in the 1980s by a philosopher who observed nurses. So the definition that currently exists in the new 2025 Code of Ethics is the experience of, first of all, believing that you know a correct ethical action to take or a professional obligation to meet. And the second part is being unable to act due to constraints that are beyond your immediate control. And so for me, when I talk to people and they say, you know, I'm experiencing moral distress, a lot of times moral distress is confused with a lot of other things. Um, when I think about moral distress, it's where your sense of integrity or your agency is threatened. And there, as I said, there is a debate about should there be subcategories of moral distress? Should be this, should be that. So the short version of the definition for me is if someone says I'm having moral distress, what I'll say to them is tell me more. Just tell me more. Let's talk about it. Because you may be saying moral distress, and as you tell me your story, it's really you're dealing with a tragic and horrible situation. But there's not really an ethics challenge. It's just really, really sad and tragic. I think it's very different than if you tell me I'm experiencing moral distress and I say, tell me more, and you tell me something along, you know, I've seen this patient's advance directive and she would never, it's very clear in this document, she wouldn't want to live like this, and the team is refusing to talk about it. Okay, now we can talk. So we can unpack the ethical challenges, like what does it mean to put something in writing? Did this patient have capacity when they made the advance directive? Did they name a surrogate decision maker? If they did, let's talk to the surrogate. If the surrogate is saying, you know, ignore what's in the advance directive, do what I say because I'm the power of attorney. Okay, well, let's talk about that a little bit. So moral distress is really complicated. I think if you're experiencing it, there's an emotional component. Good news is that means you care. The bad news is if you don't acknowledge that emotion and set it aside, you're gonna have trouble reasoning through the situation. I tell people all the time, if remember the last time you were really, really angry at somebody and you tried to have a conversation with them when you were really, really angry, how'd that go? And most people will say, not that well. So there's emotion, there's a judgment, right? You've made a decision about what you think is the ethical thing to do. And here's where there's a lot of debate in the literature. Like, what if you're wrong? What if you think the right thing to do is X, Y, or Z, but either A, you don't know the whole story, or B, you think it's right because it's what you would choose, but it isn't what the patient would choose. And what the patient is choosing is ethically permissible and defensible. So that's why the unpacking it is really important. You've made a judgment. And then the last piece of it is I'm supposed to do something, right? I'm a nurse. I'm supposed to be an advocate. I'm supposed to do this. What am I supposed to do? What's the behavior? Sometimes the behavior is simply speaking up. Sometimes the behavior is calling somebody. Sometimes, hopefully not frequently, the behavior is standing in the way of somebody trying to do something to a patient that isn't correct. So all of those are things when I think about moral distress. Those are the things that I think about. I will say though, in having a conversation with your colleague Dan before agreeing to do this, we talked about, what about nurse leaders? So nurse leaders are often facing situations of the principle that people ignore a lot because it's really hard to sort out, and that's justice. They're often dealing with resource issues. They're dealing with, how do I fairly evaluate somebody? They're big things. They're maybe not in the moment at the patient's bedside things, but they're no less challenging, no less morally distressing.
It, and and I'm wanting validation because I do believe that that ties pretty closely to kind of burnout, both nurses at the who are providing care at the bedside and nurse leaders.
Yeah. So, you asked me, what are the ramifications? What are the consequences of moral distress? So first of all, if you experience it, and you decide you don't need to deal with it, you're gonna, be resilient, you're gonna do some mindfulness, maybe some yoga. That's great. It's gonna navigate your stress, but it's not gonna help you unpack the ethical challenge, which means you've just sort of stuffed it. What that means is, over time, those episodes of moral distress are going to accumulate. So we know that, and the literature is very clear here, nurses and all healthcare professionals actually, who experience high levels of moral distress, they have physical, emotional, and mental health symptoms. They're at risk for leaving not just their job, but their profession. We think that when people have this buildup of the residual distress that they never dealt with, it's a buildup of what we call moral residual. And that's what leads people to leave their profession. Some people will call that moral injury. Some people will call it a crescendo of moral residual. But what it is just the cumulative effect. So what if I'm a patient and somebody's taking care of me, they have moral distress? Well, one of the strategies for navigating moral distress is to distance yourself from patients. So less attentive patient care, people coming to work and saying, please don't give me that assignment today, I just can't do it. Not going to do that. So the patients get less consistent care. What about organizations? Well, if people are at risk for leaving their job, they're at risk for turnover in your organization. Bedside nurses, nurse leaders, everybody knows that turnover is expensive, not just in monetary terms. One of the things that people fail to think about is it's not just that nurses are leaving the profession, it's that the wisdom that they've gained is lost. So, when I think about bedside nurses, please, if you have moral distress, don't just, deal with it on your own. Talk to somebody about it. If you're a leader, being mindful of your staff's level of moral distress is really important. I will say, in 2017, before the pandemic, the National Academy of Science, Engineering, and Medicine actually put out a statement endorsed by the Surgeon General at the time. And that was, we are not paying enough attention to the well-being of our healthcare providers. And so I think it was in 2021 or 22, the Surgeon General put out a thing saying, basically, everyone who's in healthcare should have an opportunity to talk about ethically challenging situations that they face. So the one intervention that has shown consistently to help people with moral distress is to talk about it. And I don't mean whine about it. I mean, unpack the ethical complexity. Really understand the perspective of people in the room so you can know, is it just me? Are other people feeling this way? Is it actually, okay, now I understand, I have all the information and now that makes sense. And you can't do that if you don't tell people you're experiencing moral distress. They can't help you unpack it.
You have to give it a name, say it out loud.
Yep.
And I love one of the things that you talked about struck me close because I believe so strongly in this, that you invite a good, healthy debate about what everybody's facing and see if we can't find our way through it in a way that makes people feel at peace with whatever it is that's going on. Yeah.
I think one of the things that I've come to appreciate is, so communication challenges contribute to ethical complexity. They also contribute to moral distress. I think when people don't feel that they can speak up or that their position matters, it's demoralizing. It makes people feel like I have to matter. Like what I do, what I think, how I care for this patient has to matter. I'm not a robot yet, right? not a robot, no AI, this is all me. And what I'm thinking, feeling matters. And so let's talk about it. Don't dismiss it.
Yeah, even if you end up perhaps being swayed in a different direction,
Mhm.
your voice was heard. So important.
Yes.
Is there any particular thing or set of things, any levers that leaders should be thinking about that can help them to give clinical nurses avenues to elevate those concerns? Should they be the first person that the clinical nurse calls? Should they be conduits to ethics committees? Tell me a little bit about what that should look like in a well-designed world.
So do you want the fantasy answer or the so in a healthy organizational environment, anybody who has an ethics challenge should be able to pick up the phone, send out a page, put in an order, ask for help from ethics. That's the ideal world, 24/7, because healthcare is a 24/7 business. Uh, so that would be the ideal. I would say nurse leaders should know what the ethics resources are in their institution, in case one of the people on their team has a question or a problem, and the nurse leader can certainly be a conduit. You would hope that they don't have to be a conduit. One of the things that I say, if you're experiencing moral distress and you haven't talked to anybody else about it, you might want to talk to somebody on your team before you call in ethics, because when you talk about it on your team, a trusted member of your team, hopefully the leader is a trusted member of the team, you may be able to resolve your distress by learning the whole story, by getting additional information, by any number of things. So I would always encourage nurse leaders to make sure that they know what ethics resources are available for their team, and make sure they're part of encouraging their team to reach out for help. We are bad at asking for help. I don't know if you've noticed that. We're terrible at it, terrible at it. And so you have to get over that hurdle, right? This is a
Yeah.
problem that it's not a negative reflection on me that I want to talk to somebody about it. Nobody's necessarily behaving badly. It feels like something's not right here, and I would like help talking it through and figuring it out. So I think the best thing leaders can do is to work really hard to establish a healthy work environment, to make it a brave space where people can come together and disagree respectfully and still be able to move forward and embrace plans as they unfold.
And that is a fabulous best practice kind of world. I love that. So I want to ask you something, and it may be something that you haven't spent a lot of time in, but you had mentioned COVID, and we've talked a little bit about what has happened around the world. I wonder if you could talk at all about moral distress in the United States, nurses' moral distress, compared to other cultures. Do we
Mhm.
do well? Do we not do well? Is that even a
It's a
fair
good
question?
question. So it's measured all over the world. If you look in the literature, nurses everywhere are measuring it. Everybody is recognizing that this thing exists across cultures. So one of the contributors to the experience of moral distress is, what are the expectations? Remember, I said 100 years ago, nurses were not expected to talk back. Nurses were not expected to speak up on behalf of patients. They were expected to follow orders, just do what they were told. So a nurse of 100 years ago, if you plopped her into the environment today, would be completely stressed out. They would have no idea how they're supposed to act. And so some of moral distress occurring throughout the world is within the culture. What are the expectations of the nurse? Because again, think about the three components. If one of the components is behavioral, that's an expectation. Can I manage my expectations? Am I expected to do X, Y, or Z? Am I allowed? Am I literally allowed to do X, Y, or Z? And so when you ask, how are we doing in the United States to compare to other cultures? I think anybody in the world who works in healthcare is experiencing moral distress, because there's a recognition wherever you are that there are not enough resources to promote health of all individuals everywhere. We don't have what we need to make sure that everyone is healthy. And that's even if everything were working well, and it's not working well. right?
Right, right.
So I think people go into healthcare because they want to help people. Whether you're working in a hospital in the midst of a pandemic, we had a recent IV fluid shortage, right? That's a different kind of challenge, different kind of shortage. What are we going to do? Whether I'm working in a rural area and all the obstetricians have left my state because of laws that have changed, whether I'm working in an inner city and we've had our 17th trauma patient because of gun violence. Like all of those are things that impacted, whether I'm working in a small rural country and I can't even get vaccines for people, even though I know vaccines are best. So it's everywhere. And I think, again, goes back to how can we live in a space where we acknowledge the work that we do is good? Is it good enough for today? And how do we manage our expectations for what we can do going forward?
Oh, thank you. Thank you for sharing that. It really does help us to understand. We might look different from
Mhm.
somewhere else in the world. And in fact, we look different from state to state
Yes, we do.
and setting to setting. I want to go back to this nurse leader question because I think it might be something that we don't explore a lot. When I
Mhm.
think about moral distress, probably the first thing that comes to mind is what I would call feudal care.
Mhm. Yeah,
Um,
absolutely.
it just comes first.
Right.
But then, there are others. You mentioned the issue of justice. What are the kinds of moral distress that leaders might find themselves in? I think you hit on a big one with, I know that this staffing is not what it needs to be, and
Right.
it is what it is.
Right. How
Yeah,
can I, as a leader, support my team when I know they're short-staffed? I
yeah.
know that they can't care for the patients the way that they want to because we don't have enough. So I have distress about how can I fix that? Nobody's magic wand is working as far as I know. So again, set the expectations for yourself. I think, other issues. So in my previous role, my job title was nurse ethicist. The pretty grandiose job title. But I was a resource, meant to be a resource to all nurses, including nurse leaders. So some of the things that nurse leaders would ask me about were how do I fairly evaluate this employee who's just done something really stupid and maybe they could be fired for it. Maybe it was a one-time thing. Maybe it was, and so I have, you know, in that sense, some people might call that moral uncertainty. I'm genuinely struggling with what's the right thing to do. And again, that goes back to how certain am I?
Mhm.
But I think, nurse leaders have the livelihood of people in their control. Like if, do I work in a hospital that gives people a second chance? Do I work in a hospital or a skilled nursing facility or an ambulatory care clinic? Do I work in a just culture where somebody makes a mistake and turns out we actually didn't give them proper training or we didn't have the policy that supports that? Do I work in an organization that says that's not about the employee? It was a mistake, it wasn't theirs. There's no corrective action for that. We're gonna do better training. So as a nurse leader, there are things that I have to think about, where as a direct care provider, I might never have considered. What are my organization's mission, vision, and values? And do they live by them? Are they words on a page, or do they really, really live by them? So I currently work in an organization that is striving to be what's called a high reliability organization. There are certain elements of a high reliability organization, which I always have to look up, so I'm not going to be able to recite them. However, things that exist in the hospital that promote it are things like safety huddles. There are things like a code of conduct. There are things like a good catch program, right? We celebrate and we encourage people to report problems because we can't fix them if you don't tell us about them. So as a nurse leader, I am always trying to promote a brave space where people can trust me and come to me and know that if they've made an honest mistake, they're not going to be punished. If they were neglectful or intentional or violated a policy with full knowledge of what it was, and there was every reason to believe that they knew what the policy was, that's a different problem. And how do I sit somebody down in the office and know that this will be an involuntary separation from the organization? And I know that that's going to have consequences. I know it's the right thing to do. It's not going to make me feel any good, any better about it. I know it's the right thing to do. And the barrier is my heart, right? My concern, my compassion for the employee, all of those things. So I think those are things that leaders have to struggle with. And we have not done nearly enough research about what would managers describe as what are triggers for moral distress. So you're right, feudal care, top of the list when it comes to direct patient care. For leaders, we don't have enough data to say, other than I can tell you from my personal experience, it's issues of resources and justice.
So spot on. I really didn't think about things that were less patient care related and more that kind of just culture. And I think just culture algorithms are so well thought out in so many cases and can give a leader some piece that I did the right thing, right? Which is what you hope you land on. But it is a hard part of leading is knowing you have to treat your colleagues, your employees, your team members with dignity as much as you treat every patient with dignity.
Right. And so think about it. A lot of people achieve a leadership position many times within their own organization. So they move from being a peer, suddenly being a supervisor. They have standing relationships with folks, and that's a personal relationship, and I find it really valuable. But when you come to my office and I'm wearing my ID, this is business. And I don't think we do a good enough job training people in that. You know, it's not the what, right? If you've got a just culture thing, that's great. It's the how. I mean, I can tell you when you go through this algorithm, I'm going to ask you these questions. If I say, tell me about your training, it looks to me like you had this in orientation. That is not a brave space. That's
Right.
not a brave. So it's not the what. Those are questions that you would ask. It's not the what, it's the how. And so I think, and I am skewed. So one of the things that you didn't say about me, but I think it's important for me to mention. So I'm a faculty member with Vital Talk, which is a 501(c). I forget how the numbers go. It's a not-for-profit organization whose mission is to train people to deliver serious news to patients. It's mostly focused on palliative care, but the essence of the skills that you learn are delivering serious news. And again, it's not the what, it's the how. Like I can say to you, Pam, I'm so sorry you have cancer. Well, right? It's factual, it's correct, it's true. However, could you just dial it back a little bit and start out with, Pam, I have some serious news we need to talk about. Is now a good time. I need to tell you that you have cancer. And you're not gonna. So I know that nurses don't deliver cancer diagnosis, but again, imagine the leader, somebody's in her office, right? You know, Jody, I need to talk to you in my office. It's now a good time. So come to the office, right? We have something serious to talk about. Right. So it's the delivery as opposed to Jody in my office, half an hour. Right.
Yeah.
It's not the what, it's the how. It's the how. And everybody can practice this. So I used to say when I would teach undergraduate nursing students, I said that what's the most frequently performed procedure in healthcare? IV, communication.
Oh, so
We
true.
talk to people, right? Speaking the same language, most things, so we think we're clear, but we're not. It's the most performed and least practiced skill. I should have said skill, not procedure. So it's the skill.
I love that you pointed out least practiced. We tend to just shoot from the hip. We think we've got it. I was actually thinking as I'm listening to you talk about the how and how important that is. One of the things that I'm passionate about it's our youngest nurses. You know, it's the nurse who is 22 years old and finding their footing, and they're completely post-COVID folks. And it made me wonder, are there things that we can do to help nurses and nurse leaders, like simulation? Are there some things that we can do that can make that a little better?
So I would say, first of all, I met some nurses who graduated, came to the hospital, and because they were in school during COVID, they never touched a human being.
Totally. Yeah,
So we have people who are young, maybe have never experienced a death in their family, somebody who's critically ill. They've been dealing with a plastic mannequin that can talk, right? But it is not the same. It's totally not the same. So I would say, and sometimes we forget this. When I was a new clinical nurse specialist, I was so excited. I wanted to do good work. I was in there. I was going to change practice. I was really excited. And I failed to let people get to know me. I failed to get to know them. So some of the things that we forget that will help new nurses the most, how about please and thank you? How about good morning? How about did you have a good day off? Like, how about let me learn something about you. Let me know who you are as a human being, right? That is one thing that we can absolutely do. So when it comes to the other things, so simulation, I tell people all the time, if you have a challenging conversation that you need to have, see if you can get one of your colleagues to practice with you and ask them to behave badly. So I use that example because I was a new nurse, had a surgeon yell at me. I didn't think it was right. I practiced with a nurse practitioner about what I was going to do. It's great. And so I had an opportunity to talk with the surgeon and I forgot to practice one thing. He yelled at me again. He didn't come to my practice session. He didn't care. And I was so unprepared. Was so unprepared. So, I mean, there is training that you can get. And book learning webinars, they're all great. Nothing beats practicing the words, practicing the interaction, like a real thing. And I understand that you can now do some things through AI. We don't have AI beings in beds when we take care of them. We don't have AI beings in the office, sitting in a chair, dealing with whatever they're dealing with. They're human beings. And so if I'm an experienced nurse and I want to reach out to a new nurse, what I would say is, hey, let me tell you about one of the most challenging things that I did. And would you like to practice what that felt like? Because it was really hard for me. Like, reach out, reach out. As a leader, it's okay to say, I know it's like your fifth week and you're probably still a little bit nervous. Have you found the bathroom? That's always a big thing for folks. Have you figured out the Pyxis? God, I hate the Pyxis. Could we just connect with people?
make them feel welcome and safe.
Yes.
I love that you use that word safe. People have to feel safe in order to share the mistake that they made or
Right.
any of those things that they're feeling. Yeah.
Right. So the mistake I made with the surgeon, the example is I thought I was going to change him.
Oh,
That was the wrong reason to speak up. The right reason was I deserve to not be yelled at. And so understanding that, like that experience helped me appreciate that, okay, he's never going to be my best friend. So the next time I had an interaction with him, after that, aha, it's not about we're never going to be best friends. I could be very matter of fact, very short, very clear, and it was fine. And it was not okay for him to yell at me. So, but it's again, setting expectations. I can't change you, but I can change me.
so well stated. I remember doing a lot of that in working with students where we would continue the bad behavior.
Mhm.
And now what are you going to do? Yeah, absolutely. And we know folks who were in school through COVID, one of the things they wouldn't do was call a physician.
Right.
It seemed to be a missing piece. So I appreciate that. You probably share my passion for our youngest nurses, who are going to take care of us someday.
Yeah, hopefully. We need you. Please stay.
Yes, we need you. We need you. Is the topic of moral distress and leadership underexplored?
Yes.
That does not surprise me.
Yeah, I think because there's so much focus on direct patient care, right?
Yeah.
I would say leaders in any profession, but especially in nursing, have one if not the hardest job, right? All the responsibility, none of the authority, squeezed between people from above telling them one thing, people from below asking for something else. And we have not supported them enough. in giving them the skills. So I remember like you used to like, oh, great, you applied and you're going to be the nurse manager. Here's the schedule, like here's this, but no, like no training. Like, what does that mean to suddenly be a leader? And even if you've gotten your master's degree, whether it's a master's degree in nursing, business administration, whatever you have, that's not the same as let's talk about, what you're going to need and the challenges and conflicts you are going to face. Let's walk through these. Right? So I'm a nurse leader, and whether you call it moral distress or not, I know I have to speak to this physician. If I don't speak to this physician, this behavior isn't going to change. My staff isn't going to respect me. And so huge barrier. How much political capital am I going to spend pulling this physician aside? Who do I need to talk to make sure I have their support? So one of my rules is never let your supervisor be surprised. So, right, I'm going to say to my supervisor, hey, Ben, I just want to let you know, this is what I'm going to do. Are you okay with this? And if it's well, let's talk about it, like, okay. So that matters, right? That matters. So I think leaders face a lot of significant challenges that are going to lead them. Maybe they're going to claim moral distress. Maybe it's, so I'm an ethics geek. Anything's an ethics issue as far as I'm concerned. But a lot of people would not name it as moral distress. But I think the person experiencing it will, and that's what matters, right? You name it that way, great, let's unpack it, let's talk it through. That's why I know I have colleagues who say, well, this is moral constraint distress. This is moral something distress. Okay, whatever you're calling it, whatever you want to name it, if I tell you I have moral distress and you're going to say to me, no, you actually have this, it's not helpful. It's not helpful. That's why tell me more is the response. And we need to invite our leaders to tell us more.
Yeah,
It's not
I
as big.
love when you said the first thing that you'll say is tell me more, say more about that.
Right.
Yeah, yeah. Do these issues, we talked about the ANA revisiting things every 10 years and
Mhm.
things are changing at the speed of light.
Yes.
What looks different, if anything, pre-COVID, post-COVID from that prior revision to this one?
So I will say one big thing. So in the previous iteration of the code, it said, nurses owe the same duty to themselves that they owe to their patients, which, would mean you have to take care of yourself in order to take care of others. But it wasn't clear from the 2015 version that you actually don't have to sacrifice your life. You don't have to, right? So you get to give, but you don't have to put yourself in harm's way. You don't have to put yourself in danger in order to take care of patients. So I think the 2025 language, and we did learn that from COVID, right? We learned it before COVID. We learned it with the SARS epidemic, but people didn't remember and I know this because I looked into it in the midst of COVID. I was a nurse ethicist, like, what could we learn from the past one? We ran out of people before we ran out of supplies. That was true in COVID as well. We ran out of people before supplies, either because they got sick or because they chose to walk away, right? We did not tell them that you didn't have to sacrifice yourself in order to care for patients. So, and every nurse in every job has faced this. Oh, God, I feel bad today, but I know they're short-staffed. I have a really important meeting. Should I go to the hospital? I'll just wear a mask. So in COVID, because we didn't know what it was, hospitals, organizations put in place adjusted absentee policies for people who got COVID because they did not want them in the building, right?
Right. Such
So
a good evolution.
I think for the code, if we can walk away with, you don't have to give 150% of yourself in order to be a good nurse. You have to be a responsible nurse. And it's an important thing for you to be able to say, time out. I need a timeout. Which again, like, ask for help, for crying out loud. Just ask for help.
Yeah, and live to fight another day.
Yes. Yeah. So I think, one of the things people struggled with in COVID, or think back to Ebola, when that was, I know a lot of organizations when Ebola, we had very few cases in the United States, but everybody was spending hours and hours and hours. What are the policies? And one of the policies that was put in place is Even if a patient is experiencing a symptom that under normal circumstances you would run into the room, you may not go into the room. That patient might die while you're putting on your personal protective equipment, and that's okay. And you have to prepare people for that. Because if you don't prepare them for that, they can't get over the fact that it's wrong because they've been trained to do it. We have to untrain them. It's the same kind of thing.
Such wisdom in that. And such a great way to not find yourself in moral distress. I wonder how well we enculturated that. I wonder.
So when in my organization, I meet with nurses in the nurse residency program. So these are new nurses coming in, and I always ask them, so how many of you in your orientation can remember a shift, or you can't remember whether or not you didn't get a break or you didn't go to the bathroom? And, and I'm like, well, that's too bad because we're counting on you to change our profession. You would never go through a 12-hour shift and not feed a patient or check their output. You wouldn't. And well enough, if you do, there's a different problem we have to discuss. But so if you wouldn't do that for a patient, we're counting on you to help us not do that to each other.
Mm.
So I'm quite certain anybody who's been in practice for more than 6 months can say that they had a shift like that. One shift like that is to be expected. 5 in a row, not okay. Every
Yeah.
time, not okay. And I think that's the blur that right? That line got really blurry, and hopefully COVID will help retrain us.
Yeah, so well stated. If the one-off is the one-off, but once it becomes the norm, it's crossed a chasm.
Right.
Yeah. Well, I do want to let our audience know as we approach our final time together that there is a Q&A space if anybody has specific questions, perhaps some ground that we haven't covered. But I also want to ask you at this point, Dr. Wocial, is there any ground we haven't covered that we should? The kind of thing that you think, while I have this moment, let me share.
That's a dangerous question to ask somebody who can be chatty. Um,
I love it.
so I think about the title, right? The challenges of doing the right thing. If doing the right thing were the easy thing to do, I wouldn't have a job. I wouldn't have
Oh,
a job, right?
yeah.
The right thing to do, and that's just it, right? You have to make choices. So I think for me, one of the hardest things that I had to do, and I made the choice, and I used to say it was the last thing I had to do before I could become a nurse ethicist. So I had a colleague whose practice I was worried about, and I reported my concerns to her boss, who dismissed them. I reported my concerns to my supervisor, different reporting structure, and she didn't dismiss them, but she encouraged me to go up the chain. So I reported it to this person's boss, dismissed it. I reported it to the chief nurse executive. And when I finally decided what I had to do was file a report with the State Board of Nursing, one of the leaders discouraged me from doing that because she was concerned about retribution I would face, not because the concerns weren't valid.
Yeah.
And I decided, and it frankly was an easy decision for me to make because I'd already chosen to leave the organization for a variety of reasons. I did file a complaint with the state board, never heard from them. Do not know what happened, but that was all I could do. And for me, like that was hard. It was hard. And I mean, I still get palpitations thinking about it because I was judging someone's practice. I was a clinical nurse specialist at the time, which is, you want to hope that your clinical nurse specialist is an expert in their practice. So I want to think that my ability to evaluate this person's competence was legit. But again, when it comes down to it, it's like my word against hers. So that was hard, but I still think it was the right thing to do.
Yeah, and as you said, if it was easy, we wouldn't talk about it very much, right? It wouldn't be a whole body of science.
Yeah, I'm going to say one more thing, although I do see there's a question. One of the things that's in the code. So in the 2015 version, there is a bit about what do you do if you're in a place where patient care is not safe. And in the 2015 version, the language kind of implied that, well, you should quit if it's not right. And the 2025 language is a little bit more subtle, and that matters. It's
Mm.
subtle that you have to make choices. You have to make choices. You may have to stay in the organization for economic reasons, but the risk you take is the practice in the institution will have an impact on you, and you're practicing in an environment that's unsafe. So you're not a bad person if you're making an economic choice to continue to be able to feed your family. If you work in a rural setting and this is the only game in town where you can have a job, that's a good reason to keep working. And report your concerns to any agency possible. So again, it's all about the subtle language, right? You don't have to quit. We know you can't. You may not be able to. Just know what the risks are to staying.
And be thoughtful about it and find peace with it.
Yep.
Wonderful, wonderful. I do want to get to our questions. We have 3 of them. Um, does debriefing play a role in helping with moral distress for teams? And is there a similar process that would help with leader moral distress?
So I'm a big believer in debriefing. I need to be clear though. So some people will say they'll have moral debriefs. There's a critical incident stress management strategy, all of these things. Bringing people together to unpack the issues matters. For me, what I know is if you are going to do it about the ethics, that requires somebody with some ethics expertise who can facilitate the discussion. So for example, without the ethics expertise and the focus, when somebody says, well, Dr. Bob was doing X, Y, or Z, and then people naturally go to Dr. Bob's terrible, and like the ethics person's like, no, come on back. Come on back. Like, we're focused on the ethical issues here, right? And so debriefings absolutely, I think, are essential. Again, I mean, I can tell you the qualitative evidence behind why that works. So people come together, they feel a psychological benefit. If you're lucky, they're going to get a learning benefit. Hopefully they're going to build community. Oh my God, I wasn't the only one, right? And those 3 things together work to build moral agency. So yes, I think those sorts of debriefings with a skilled facilitator would be hugely beneficial for leaders.
And that idea that you're not alone is huge.
Yes, it is.
So thank you for that. All right, we have a couple more questions. I appreciate your thought on institutional leadership and moral distress. Can you address any specifics regarding the perceived moral distress in higher education and nursing faculty?
I do have thoughts about it. Read that one more time. I want to make sure I'm addressing the question, just the last part. So, oh, I can, hang on, I can see it. So institutional leadership and the perceived moral distress in higher education. So I can tell you in higher education, we have faculty who are facing significant challenges on multiple levels. It's hard for me to know whether or not you could describe it as moral distress. I think any faculty member who's engaged, they know the right thing to do is to give their students the best learning opportunity that they possibly can. And there are all kinds of barriers to them being able to do that. Curriculum, accrediting bodies, a sense of teamwork. My experience with colleagues in faculty roles is sometimes they're not as cohesive a group as they could be. And when you think about it, that makes a lot of sense. They're all in the same building, they're teaching multiple students, but other than coming together for faculty meetings, they may not actually have formed good relationships with each other. And so some of the moral distress, I think, related to the work environment is, how do I know what the right thing to do is? Because I don't really have good relationships with my colleagues. So I know that that nursing faculty experience a lot. I know that we have faculty, we're trying to expand the diversity of our faculty, and that, like anything else, comes with significant growing pains. So I wish I could say more about it. Again, we haven't done enough research to know exactly what is at the nature of it. But like anything else, if you unpack the 3 things, I don't think something's right. I'm going to make a judgment about it, and what am I supposed to do about it? Think about all the constraints on faculty. And for many faculty, it's time. It's time, and oh yeah, now I have to teach online. I don't even have a Facebook account. What do you mean I'm supposed to teach online? That would be me. So, there's a significant amount of stress. Is it moral distress? Maybe, because it is compromising who I think I am as a faculty member. So I would say, sadly, tell me more. Let's talk about it.
Such a great question. Such a great question from a different sector. So
Hmm.
last question is, where do you think the industry is in supporting bedside nurses proactively in making tough choices and doing the right thing and more? Where is the industry in supporting them? What do you think?
So I will say, when I was hired as a nurse ethicist a long time ago, so it's like, yeah, I'm old. Um, I was one of probably 5 people in the United States that had a job title like that. We have a lot more people with job titles that are similar to nurse ethicist, senior ethics nurse leader, like whatever you want to call it. So what is the industry doing? I think there's a recognition that there's a need to have a resource in place for nurses to be able to tap into ethics challenges. And so some organizations have a nurse liaison program. Some people have it as a nurse champion. So there are different flavors of what can you do to empower people in direct care to do the right thing or to know what resources are available. So I would say the industry as a whole may be recognizing it. It's interesting that you asked me this question because as a chair of the healthcare ethics consultation certification commission, this is something we think about, right? I mean, I can tell you the data shows us that around 27,000 people in the United States claim to practice ethics consultation. Over the time that certification has been possible, 844 people have gone through certification at one time or another. That's 3%. That's 3%. It doesn't mean that the 27,000 people who aren't certified aren't qualified, but it means they're not. And we don't, like, you come to ethics consultation through multiple different paths, and we find that valuable and encourage that in the profession, right? Chaplains, social workers, lawyers, nurses, physicians, pharmacists, right? All of those people come with a lens, which is important because it broadens perspective when you're trying to unpack an ethics challenge. Some people, so I tell people all this time, they find it surprising. I don't have a degree in ethics. My minor field of study in my doctoral program was healthcare ethics. So, I now do clinical ethics full time. So what's the industry doing? There's a growing recognition that we need people with ethics training, both to teach in schools of nursing. So American Nurses Association partnered with the National League for Nursing to create a module to teach faculty how to teach ethics. Because sometimes you come to work and like, you're going to teach the ethics course this semester. Like, pharmacology person. Don't make me teach that. And so the industry, whether it's professional organizations or institutions that hire people, there's a recognition that ethics is important. We need to train people to teach it. We need to have resources embedded within the organization. So I think there are baby steps. It's not enough. I want more. I want everybody in a healthcare organization to be able to have access to an ethics consultant 24/7. We're not there yet.
Yeah, the increased awareness of the need is huge.
It is. It
Yeah,
is absolutely huge.
wonderful. We are running out of time, and I don't want to leave anybody hanging. I do want to let you know that the webinar is recorded, but we do have a question. Would you please repeat your definitions of distress?
Yeah, so believe it or not, I knew this question would be asked, and so I decided that I would take notes. So the definition that I shared, and I'll also point out that if you go to the Code of Ethics, you can find it there. So the Code of Ethics definition of moral distress is the experience of A, believing one knows a correct ethical action to take or professional obligation to meet, and B, being unable to act due to constraints beyond the immediate or individual's control. And this is something that threatens your sense of moral integrity. And there's a debate in the literature about whether this definition ought to incorporate other morally troubling situations. So It's not a settled definition. I appreciate that you're asking for that one. That is the one that currently appears in the code.
Wonderful. Thank you. Dr. Wocial, we are so incredibly grateful for your time. We have reached our hour, and so I want to be respectful of your time and the time of all of our attendees. I do want to remind everyone to complete an evaluation. We are currently planning webinars always. We are so grateful for a webinar of this quality and a guest of this quality. We invite any future recommendations that you have. I know that everybody who listened to this hour walked away with huge benefit. And I think even if they walked away with more questions than answers, I think that's fabulous. I think that's kind of the getting thought going that has been a result of stimulating time together. But you have made something complex very accessible. I think we all have a lens that we did not have an hour ago, and I am so very grateful that you gave us that wonderful gift.
Thanks so much. I appreciate the opportunity. And good luck to all of your attendees.
Wonderful. Thank you so much. Have a wonderful rest of the day.
Bye.
Bye.